Good afternoon, everyone. Welcome to the Kirby Institute seminar series. I believe this is the first seminar for the year, so happy 2026 is still allowed to be said. My name is Richard Gray, and I'm the head of the Mathematical Epidemiology and Evaluation Research Group at the Kirby Institute. I would like to begin by acknowledging the traditional custodians of the lands we all gather on today and pay my respects to their elders past and present. Today, the seminar is being presented from the lands of the Bidjigal people of the Aurora Nation. And I want to extend that acknowledgement and respect to any Aboriginal and Torres Strait Islander people joining us in the room and online. So before I introduce our speaker, there's just a couple of housekeeping notes to be mindful of. So today is a hybrid seminar. So we have people in the room and online. For those online, there will be a Q&A facility to put in questions during the seminar, but the way the seminar is being run is that there'll be presentation and then we'll have the Q&A at the end. Just for those people in the room, a reminder that we need to use microphones when we're asking questions so that the people online can hear what you're asking. Okay, so I'd now like to introduce our speaker, William Green. Will is a research fellow at the London School of Hygiene and Tropical Medicine in the UK. He did a BA and Masters in Natural Sciences at Trinity College in Cambridge before doing a PhD at Imperial College, doing things that a lot of modelers were doing at the time, looking at SARS-CoV-2 viral dynamics. Previously, Will has worked as a consultant at the UK Cabinet Office and UK Health Secretary Agency during the COVID pandemic. And then he's also done some work with the World Health Organization on the mpox outbreak and in the Democratic Republic of Congo, and also looking at polio eradication. Currently, he works with Professor Sebastian Funk at the London School, and his interest is in forecasting epidemics among men who have sex with men, and he's visiting UNSW on a Royal Society Exchange Fellowship. So today we'll be talking a bit about networks of MSM and how to model them to capture the complex partnership networks that are formed so that we can model and understand and forecast infectious disease epidemics in that population. Okay, Will, over to you.
Awesome. Can everyone hear me okay? Okay, nice. Thank you for the introduction. As mentioned, I'm a postdoctoral research fellow at London School of Hygiene and Tropical Medicine, where I work with Sebastian Funk. I'm going to talk for about 35 or 40 minutes today about my work in robust forecasting of infectious disease epidemics in men who have sex with men. I do have a habit of talking somewhat quickly, so I'm going to try and speak slowly, but if I do go too quickly, please do slow me down. So my talk today is going to be split into 4 parts. I'm going to start by talking about the background and motivation for the work. Then I'm going to talk about constructing plausible MSM networks. MSM is men who have sex with men. Then I'm going to talk about forecasting in MSM networks, and then I'm going to talk about results and next steps. Just a note on kind of wording. When I talk about a network, I'm talking about a group of people who are connected through sexual contact. I'll use person and node interchangeably, and kind of contact or edge interchangeably. Okay, so background and motivation. So as I'm sure most of you know, men who have sex with men represent an epidemiologically unique subgroup in the population who are more vulnerable to a variety of infections. So I'm sure most people know of the HIV epidemic. Prevalence in MSM is typically about 20 to 30 times higher than in the general population outside of sub-Saharan Africa, where it's more like 3 to 4 times higher. If we think more recently, the mpox epidemic of 2022, so the top right graph is the daily incidence of mpox in the UK. Over 95% of cases in the UK were in MSM. In some European countries, as many as over 98% of cases were in MSM. And then perhaps a less well-known one is the bottom left. This is diagnoses of 2 strains of Shigella. among MSM. So this has been growing for a number of years now, aside from a small drop during the COVID pandemic. In more classic STIs, the incidence of gonorrhea in MSM is about 90 times higher than in the general population. So MSM account for about 2.5% of the population of London, but about 70% of the gonorrhea diagnoses. So why are MSM particularly vulnerable to these infectious diseases? Well, there's a few driving factors, principally very high contact rates. And this is from both concurrent partnerships, so this is recurrent sexual interactions with one or more people, and also one-time partnerships, so colloquially maybe known as hookups. There's high overdispersion, so a small number of people have a very, very high number of contacts. And the transmission efficiency of STI transmission through anal sex is typically higher than vaginal sex. There's also higher sortativity and super spreading, so increase in use of sex on premise sites. Participation in group sex or chemsex means that we sometimes see super spreading dynamics, which we don't often see with heterosexuals. So just to put some numbers to this, so the top left graph here is a log-log plot of the relative frequency against the number of unique partners over a year. Across the entire distribution, MSM have approximately 10 times the number of unique sexual partners as compared to the heterosexual counterparts. So, for example, the top 1% of MSM have more than 100 unique partners a year, as compared to 10 unique partners a year for heterosexual men. This is for data in the UK. Obviously, there's a lot of geographic variation. If you look at the top right graph, this is reporting of concurrent sexual partnerships. So this is repeated sexual interactions which happen with more than one person. This is very important in disease dynamics because kind of temporal closeness increases the density of the connectedness of your network. If you think of two extreme cases, you could think of somebody who has one sexual partner a week for every other week versus somebody who has 26 sexual partners in 1 week and none for the rest of the year. Obviously, the denser connectedness means that infectious disease transmission can happen more easily. And then the bottom left here, this is the transmission risk of different exposure routes for HIV. So receptive anal intercourse is about 14 times higher risk than receptive vaginal intercourse. And the second highest in terms of sexual modes of transmission is insertive anal intercourse. Okay, so I want to talk a bit about the complexities of the MSM network. So I guess the principal complexity is, as I mentioned before, this very high heterogeneity. So you have a small number of people who have a very high number of contacts, and then most people will have 1, 2, or 3 unique contacts a year. And this basically squashes this standard assumption we have in a lot of infectious disease modeling, which is this idea of homogeneous mixing. A second important feature is the feature of sexual role. So we can broadly split the population into purely insertive, purely receptive, and versatiles. And this has important implications for transmission dynamics when we think about things like directionality of transmission. So yeah, the network has a lot of features, and I split these in this slide into kind of measurable features. So this is like the number of nodes. So what's the size of the MSM population? The degree distribution, that's the degree of the number of contacts you have over a year. The role distribution, distribution of concurrent partnerships. And then if we think about epidemic features, we have like incubation period, infectious period. But then we have these more hard to know variables. So the variables on the left, you can kind of get an assessment of by just doing questionnaires and asking people about their sexual behaviors. But you can't really easily measure these features on the right because they would require nodes to have information about the nodes they're connected to. So degree and role assortativity, I'll talk a bit about on the next slide. We have clustering, so that's if A and B are contacts and B and C are contacts, what's the probability that A and C are contacts? Spatiality, so how much more likely are you to have a sexual interaction with somebody who's 500 meters away versus 1,000 meters away? And then features of epidemics which aren't known early on, so things like the per act transmission probability and transmission directionality. So degree and versatile assortativity. So on the left here, I've just got a heterogeneous network. But if you look in B, this has the same degree distribution, but an increase in degree assortativity. So this is the tendency for highly connected nodes to connect with other highly connected nodes. And that has important implications for epidemic dynamics. So the more highly connected, the more high your degree of sortativity, the more explosive your outbreak will be, and then the quicker it will tail off. And then in C, I look at increasing versatile sortativity. So this is the tendency for versatiles to preferentially connect with other versatiles, and for insertives to preferentially connect with receptives over versatiles, for example. So I kind of split these features into four different categories. So I kind of have in blue, like what I call first order structural features. In green, kind of temporal structures of the network. In light orange, these are kind of second order structural features of the network. And in dark orange, these are kind of epidemic parameters. And so the objective of my work is to develop a method for forecasting infectious disease epidemics in men who have sex with men that accounts for early depletion of highly connected nodes, so that accounts for this high heterogeneity and quick burn through of the highly connected nodes, but is also robust, independent of our uncertainty in these other network features. Okay, so how do we do this? So we typically have pretty poor data on epidemics in men who have sex with men. So if we think about the mpox epidemic, we have daily incidence data for 5 cities, so Barcelona, London, Madrid, New York, and San Francisco. But that's not really a sufficiently big sample size to kind of have statistical strength in saying this forecasting method is better than this forecasting method. And so in the first part, what we want to do is augment our data set. So we want to generate a set of plausible epidemics in MSM networks to apply different forecasting methods to in order to kind of confidently say this forecasting method is the best, and it's the best independent of all of the uncertainty we have in the specific network structure. And so to do this, what we do is it's a 3-step process. We generate 100 plausible MSM networks and simulate epidemics on each of them. Then for each of the epidemics, we take 10 equally spaced cutoff points on each network and assess the forecasting ability of 8 different models. And then using that, we identify the best model, which is robust, independent of network features, and ideally, which is robust, independent of the phase of the epidemic we're trying to forecast. So just to do a little mini summary, so MSM are vulnerable to epidemic diseases owing to a combination of high contact rates, higher transmissibility, and temporary close or overlapping partnerships. The MSM contact network is complex and poorly parameterized. Some features like degree distribution and recurrency are measurable, but we only have this in certain geographies. Some features like degree and role sortativity are harder to parameterize independent of geography. Our aim is to identify a new forecasting method, an attenuated renewal model that can account for depletion of highly connected nodes and is robust, independent of the intricacies of the network. And so in this work, we're going to construct MSM-like networks, simulate epidemics on them, and use that to assess the optimal forecasting model. Okay, so constructing plausible MSM networks. So I talked a bit about the degree distribution and sexual role, but another important feature of the MSM network is that it's really a combination of 2 networks. There's the one-time network and the recurrent network. So recurrent networks are these sexual interactions which happen with some frequency, maybe every 5 to 7 days, and that can happen with 0, 1, 2, 3, or 4 partners. So these are slightly stronger connections, right? Because you have multiple opportunities for transmission during an infectious period. So that's why I indicate them on the graph with slightly bolder lines. But the recurrent network, you're kind of limited in how many recurrent partners you can have just because of like time considerations. So the one-time network is really where the like high over dispersion is. So this one-time network is where you see some people having like over 100 partners a year, whereas in the recurrent network, we kind of limit this up to 4 potential concurrent partners. I also use recurrent and concurrent interchangeably, by the way. And so the kind of overlapping sum of these 2 networks gives us our MSM-like network. Okay, so how do we construct the MSM network? So this box represents a city, and each of these points represents a person. So we generate individuals at random onto a unit square. For each node, we sample the total number of partners they have based on the power law. That's kind of the graph I showed early on. But we use plausible different alpha parameters here because in different cities there might be different kind of levels of overspersion based on kind of acceptance of MSM or things like that. From that, we sample the number of recurrent and one-time partners. So this person in the middle, like, oh, Can you see the mouse? Yeah. So this person in the middle, we say they've got 6 partners. This person up here has 4. From that, we sample how many of those are recurrent and how many of those are main based on a pre-known distribution of the frequency of certain recurrent partnerships. Then we assign each node a sexual role, insertive, receptive, or versatile. Based on the node characteristics, we calculate the probability of connections with each other node. So let's say green in this case is insertive. They can either connect with orange, which is versatile, or blue, which is insertive. That's kind of what I mean about role compatibility. Based on different levels of versatile assortativity, you might have stronger connections between versatiles versus versatiles and receptors or insertives. There's some spatial considerations, so close nodes which are close together are more likely to connect with each other. And there's an assortativity consideration, so how preferentially do nodes connect with other nodes of a similar degree? So from all of those, we know the middle person only has 6 contacts. So we sample a set of partners from all of the potential options. We sample 6 partners without replacement, weighted by those probabilities. And then we iterate this over all nodes. And from that, we can set up our entire MSM network. So TLDR, connections form probabilistically and are more likely with nodes that have more sexual partners, are spatially close, are a similar activity level, and exhibit close role compatibility. I won't go through this, but this is basically just the probability of I and J connect is based on those four parameters I just described. But we have different kernels and different ways of treating each of these variables. And then simulating the epidemic. So epidemics are simulated using an SEIR model. Infections occur probabilistically after contact with an infectious individual. So this middle person had interactions with 6 people. 2 of them were infectious. The probability the person in the middle becomes infected is based on the role-specific per-act transmission probability. And each sexual contact is an independent transmission opportunity. So risk accumulates across all infectious partners. So yeah, I said we simulate epidemics over 100 different MSM networks. So this table just gives you a sense of the different variables we consider. So we do Latin hypercube sampling over these to get a good span across all of the distributions. So I think for all parameters, we kind of Latin hypercube sample from a uniform distribution. So we consider network sizes from 25,000 to 50,000, assortativity kernels from disassortative mixing to assortative mixing. I won't go through all of them, but maybe directionality, for instance, we consider no directionality up to a 5 times higher transmission directionality. Anything else to mention? And yeah, we consider a range of different incubation periods and infectious times. Okay, so moving on to forecasting MSM networks. So I'm not sure who knows about the renewal equation, but I'm going to give a little run through of what the renewal equation is. So the renewal equation is basically a very simple approach to estimating how many infections am I going to have today based on the infection history of the last, few weeks. And so there's some important parameters here. So there's the basic reproduction number, which is the expected number of cases generated by an infected person in a totally susceptible population. However, immunity acquires in the population, and so some of these transmission modes will be blocked. And so the effective reproduction number is the expected number of cases generated by an infected person accounting for population immunity. So in this case, suppose a third of the population is already immune, while one of those 3 potential transmissions is blocked, and so the effective reproduction number isn't 3, it's 2. Also important to the renewal equation is the generation time distribution. So this is how the timing of onward infections is distributed. So in this, I've assumed like a very simple generation time distribution where 25% of your infectiousness is on day 1 of your infection, 50% is on day 2, 25% is on day 3. Remember those numbers for the next slide. Okay, so this is my timeline. The current day is T, the days before T-1, T-2, T-3. This is my infection history. So 3 days ago, 4 people were infected, 2 days ago, 6 people, and yesterday, 4 people. And I want to know how many people are going to be infected today based on this. Okay, so we've got the reproduction number. Let's say the reproduction number on day 1 is 2. And we know from the last slide, from my simple assumed generation time distribution, that 25% of my infectiousness is on day 3 of my infectivity, because this is 3 days ago. And so the number of infections we expect today from people who were infected 3 days ago is the product of these. So 4 times 2 times 0.25, which is 2. We can iterate to the next day. So 2 days ago, 6 people were infected. The RT is about 2. It's maybe gone down a little bit because population immunity is built up. But more of our infectiousness is concentrated on day 2 of our infection. And so the number of people we expect to be infected today who had their first day of infection 2 days ago is 6. Likewise, for yesterday, ours gone down a little bit, but we'll neglect that. Less infectiousness on day 1, so 2 people. So the total we expect is 10 infections today. So this is kind of how you formalize that. So new infections is a sum of past infections weighted on their infectiousness, where infectiousness is the composition of the reproduction number and the generation time distribution. Okay, so what's the problem with the renewal equation for MSM outbreaks? So as I mentioned, the MSM network is highly overdispersed or highly heterogeneous. Typically, the effective reproduction number is calculated as the basic reproduction number multiplied by the proportion of the population who are still susceptible. But this doesn't work in highly heterogeneous networks, such as the MSM network, where different individuals have markedly different impacts on population immunity. So if we look at the kind of in the homogeneous case on the left, where everybody has the same number of contacts, this is broadly fine to assume because everybody contributes equally to population immunity. But if we think about the heterogeneous network, well, if this node becomes immune through natural infection or immunity, then that has a massive impact on what the reproduction number is because the proportion of edges of the network they occupy is higher than the proportion of nodes that they occupy. And these people are going to be infected early and they're going to infect a lot of people early. And so they're really, really important to transmission. And so what we want to do is adapt the renewal equation to account for the fact that there's early depletion of highly connected nodes. And so we replace the basic reproduction number here, R0, with a monotonically decreasing function R of t. And in our work, what we're going to do is assess different kind of functional forms of RT to see which is robustly the best, again, independent of these intricacies of the network. Okay, so what forecasting approaches do we take? Well, we have 2 which are purely statistical approaches, which don't use the renewal equation. These are just random walk approaches. They say the incidence today is just going to be drawn from a distribution centered on the incidence yesterday and some standard deviation. The third one is this random walk in R, which is a standard renewal approach, which doesn't account for this depletion of highly connected nodes. And then the last 5 here are all kind of attenuated versions of the renewal equation. So we have a biased random walk in R. So that's a random walk which is kind of pulled down by a drift term each day. Exponential decay through time. So we apply an exponential discounting to the reproduction number after a certain time point has passed. Again, these are all parameters we fit. Exponential decay by attack rate. So, the first 1% of people have a big pull down on the reproduction number. The next 1% have a big one, but not quite as big pull down. And we also consider power laws and reverse sigmoids. I guess the exact form isn't that important, but just to give you a sense of what we try. So yeah, and then just put a different way, we've got no attenuation, this R rand, attenuation in time, bias random walk, exponential in time, sigmoid in time, and attenuation and attack rate. So exponential attenuation or power law attenuation. Okay, so how do we score the forecast? So we simulate epidemics on 100 plausible MSM networks. For each outbreak, we choose 10 different cutoff points, which are equally spaced. So there's just one example here. So that's one cutoff point shown by the dashed line. We remove the data after the cutoff point, so we pretend we don't know what's going to happen. Then we use each of our 8 forecasting models to predict how the epidemic will evolve through time. And then we compare that to the true data for the forecast prediction. And we score using the CRPS. So CRPS is continuous ranked probability score. I won't go into this either, but put simply, CRPS asks how much probability mass do you place near the truth and how much do you waste far away? So CRPS is a good CRPS is a low number. You are credited for having a prediction which is close to the truth and which has a narrow confidence interval. and you're discredited if you predict far away from the truth or and with low variation, I guess, as well. Um, and then so we do 100 MSM-like networks, and then we do 30 just simple heterogeneous networks and 30 homogeneous networks to give us like comparator points for this. Should we always use an attenuated renewal equation, or do we only need to use it in certain cases? Okay, so then the results. Okay, so this is a table of the mean CRPS across all simulations. The first 5 columns are applied to daily instance data for the mpox outbreaks in London, Barcelona, Madrid, New York, and San Francisco. The 6th column is the application to homogeneous network. 7th is application to heterogeneous network, and the 8th is these MSM-like networks, which is this, combined one-time and recurrent network with sexual role and assortativity and everything. Yeah, and the numbers give the mean CRPS scores by place and data source, averaged over all simulations and all epidemic cutoff points. So the good news is we have like one clear winner, which is this sigmoid attenuated form. So maybe let me walk through step by step. So in the homogeneous case, when we typically think the renewal equation is the best, we have like good evidence that the just random walk with no attenuation is the best performer. The best performer in each column is shown in bold. In the heterogeneous network, as soon as you have any like heterogeneity with high overdispersion, then applying some attenuation is pretty good. And what's cool about this is we don't kind of presuppose what the attenuation is. We let the model run and do the fit. And actually, from early epidemic instance data, you can pretty quickly get an idea of what this attenuation is. And then the benefit of a sigmoid attenuating model is even better when moving to an MSM-like network. And I'll talk a little bit about why we think that is in a few slides. And then for 4 out of 5 cities, the sigmoid attenuated model was the best, with the exception being New York. New York had some funny dynamics of the mpox outbreak, which is always hard for infectious disease modeling to capture. But yeah, such is life. I mean, it's still the second best. So. And then this graph shows the CRPS measured on the linear forecasting scale and the CRPS measured on the log forecasting scale for each of the 8 models at each epidemic phase. And the good news here is that the sigmoid model, which is shown in the far right, is the best independent of epidemic phase 2. So even in an epidemic where you've only had 5% of what the total number of infections will be for the epidemic, you already have pretty good forecasting power, pretty good ability to infer the delta, the attenuation variable when you're fitting. And then this just gives, well, so each row is a different model, and yeah, there's incidence on the y-axis. The points are what happened in the simulated epidemics, and the lines with the ribbons are the model estimates, the ribbons giving the 95% confidence interval. The bottom row here is the sigmoid. So again, you can see if we look at columns 1 and 2, even very early into the epidemic, so this is epidemic phase 2 being shown with the light blue ribbon, you get very good kind of prediction of how the epidemic will evolve. Also, the y-axis is a log scale here. So the second row, which is the random walk in R, which is the standard kind of homogeneous assumption approach, is like way off, like by a factor of 10 or something. And that's just because of how important the people who are infected early in the epidemic are, because they're so highly connected. They're kind of like doubly important because they both get infected very early and they infect a lot of people very early. Okay, so why is the sigmoid model the best? So as I've mentioned, epidemics and MSM occur on overlapping networks with different intrinsic basic reproduction number. So you can think of this kind of one-time network, which is driving the early epidemic, where you've got people who have very, very high number of contacts. And then you can think of this recurrent network, which is driving the late epidemic, because it's kind of like these people don't have high number of contacts, but they have kind of stronger contacts because they may have 2, 3, or 4 sexual interactions over their infectious period. And So, when we simulate, maybe about 80% or 80 to 90% of early infections are driven by the one-time network. And at the epidemic cessation, about 80% of infections are driven by the concurrent network. And the sigmoid basically allows a smooth transition from one paradigm to the other. So these plots here show the case reproduction number against time for 6 different simulated epidemics. And you can kind of see that the points are what happens in the simulations, and the lines and the ribbons are our best model fit. Sigmoid is very versatile, right? Because it can allow for just like an instantaneous exponential like decrease if your early infecteds are these like super highly infected people. But sometimes it might take a little while for the epidemic to find those highly connected nodes. Maybe the first imported case is somebody who has, 5 contacts a year rather than 100. And so it takes, a couple of generation intervals for those highly connected nodes to be found. And sigmoid allows for that dynamic as well. So key findings. So sigmoid attenuated renewal models substantially improve short-term epidemic forecasting in both simulated and real-life MSM networks. It consistently outperformed standard renewal models, statistical baselines, and other attenuated forms. It captures the preferential early depletion of high-degree individuals in MSM networks. And it only requires incidence data and an estimated generation time distribution for it to be implemented. The method is computationally simple, interpretable, and deployable early in outbreaks and before behavioral or contact tracing data are available. So, I mean, what's nice about it is we didn't need to know anything about per-act transmission probability or transmission directionality or degree of sortativity to be able to implement this. The sigmoid attenuated model, we are inferring, 5 parameters, which is like a basic reproduction number, a floor to the reproduction number, an attenuation term, and a center point to that attenuation. I think I'm probably missing one parameter, but so yeah, it's a great method. So then broader relevance. So I mean, this work was kind of born out of some work I did in World Health Organization last year. Where I was looking at the mpox outbreak in DRC, which isn't principally driven by sexual contact. It's a mix of sexual and close social contacts. And one of the jobs I had was kind of coming up with the vaccine demand estimate, like how many vaccines should Gavi procure and which provinces should we send them to? How should we allocate them? And the dynamics of the mpox outbreak in DRC you couldn't explain from build-up of population immunity because such a low share of each province had actually been infected. And so this kind of came out of that, like how do we account for this kind of peaking of the epidemic, like when population immunity is sub 1%. Um, and so this is also kind of applicable to that kind of dynamic, right? Because that's not an overlapping one-time and recurrent network, that's an overlapping sexual and social contact network. You can also think about respiratory infections. So if you think about SARS-CoV-2, you can think of that as household transmission, which is a small number of very close contacts, and then kind of extra household transmission. So community transmission, which is generally a higher number of more kind of low intensity contacts. And I mean, there's been multiple papers with SARS-CoV-2, where you look at things like household size is a good predictor of infection early. That's kind of a one-to-one mapping almost of kind of high connectedness is a important risk factor early on in MSM. And then there's also nosocomial transmission. So this is less like 2 directly overlapping networks, but you have healthcare workers who are very high contact and patients who are much lower contact. And so that's, again, you can kind of see that there being a comparator there of 2 overlapping networks. So future work. So the work I just presented is a first paper that we're submitting in the next week or so, just waiting for some final runs. But we're hoping to extend this more now. So the work I just did was basically how can we best forecast total incidence? But like a related question is, what data would you collect in a future epidemic in men who have sex with men to optimally forecast how the epidemic is going to evolve and optimally forecast how you should implement certain interventions? And so I've been working with UKHSA on this, and I mean, you look at the UKHSA data, they have almost 100 columns of data, but actually very, very few of them are relevant to forecasting. And you can imagine it's quite easy to get data such like somebody comes in with mpox, you can ask them how many sexual contacts they've had in the last 3 months, and what their sexual role is, and how many recurrent partners they have. And then maybe we could use this kind of risk stratified data to improve forecasting. And so what we're now considering is this kind of stratified renewal equation, which is the standard renewal equation, using population immunity and the basic reproduction number, but adding this extra term xi of k, which is the kind of weighting you should apply to that group in terms of their risk. So yeah, you can think insertives, versatiles, and receptors may have different importance if directionality is very important, or if so yeah, for instance, in HIV. But you could also think of, okay, have you had more than 50 partners in the last year? Have you had 10 to 50 partners? Have you had 1 to 10 partners? And again, those are going to have very different weightings. And so we have some early results for this. So this is stratifying. We stratify into 4 groups, which is kind of 80 or more partners a year, 27 to 80 partners a year, 9 to 27 partners a year, or 1 to 9 partners a year. So group 4 is the highest contact group. You can see in the simulation, they kind of peak early and they kind of go down very early. Using this stratified renewal equation, you can see like how good the fit is to the network dynamics in the top. So I think like we're going to use this as a basically to sell to public health departments exactly what kind of data they should collect. This isn't just applicable to MSM, this is more broadly applicable. But yeah, that's my project for the next 2 months. Yeah, that's all I was going to talk about in this presentation. I don't think I have another slide. Oh, that was supposed to say thank you. But yeah, thanks for attending and happy to take any questions.
Leo, on the microphone.
Feels really cold.
Sure.
Thank you so much. That was a really interesting talk and I learned a lot. I was just curious if you're planning to bundle this as an R package. I think you're using R from what I can see. It'd just be great to forward simulate under your model.
Yeah, that is a good point. We actually should think about that. I mean, the model is actually implemented in Stan. We use HMC. It's actually very easy to kind of do without a package, but I know people do like simplicity. I mean, maybe I will. It probably isn't a priority time-wise, but I'm happy to have a master's student do it.
Please.
Michelle.
Yes. So after generating all the nodes, the degree distribution, it follows the power law, right?
Yeah.
So how do you split the degrees into like concurrent partnerships and also a one-time partnership?
Yeah. So okay, the kind of background, what we know we might have in a place is like the degree distribution. So we might have the parameter describing the power law. And so what we can do is say each of these nodes has like, we can say how many unique partners they'll have over a year. And then we also separately have some idea of like, well, we're simulating, but you know, in real life, if we're doing it for London, we have some idea how many people have 4, 3, 2, and 1. So from the degrees who have more than 4 total partners, we sample from them, okay, well, we know we need to make overall 27% of people have 2 recurrent partners or something. And so we can kind of go through this iterative process of, okay, assigning out the people who have four recurrent partners, then assigning the people who have 3, then assigning the people who have 2. So yeah, that's basically how we do it. You basically, your recurrent partners obviously can't exceed your total number of partners, so we have to draw from the people who have that number, but we know what the end distribution we want to end up is with. And then for the simulations, we actually simulate kind of a range of these percentages. But for London, for instance, we know what the degree distribution and the recurrency rate is.
Thank you. That's very insightful.
Andrew.
Not a modeler, as you know. So, you know, I'm a public health person and can really see the strength of your approach to deciding who to target in vaccine programs. And as we were talking last week, it sort of helps explain why places like Australia, which seem to have relatively low mpox vaccination rates of maybe 30 or 40%, have achieved disease control. It doesn't quite make sense unless you think of this sort of degree of clustering. It would be for policy, for the decision makers in health departments, it would be really amazing if you could use that to sort of ask questions such as, if we had a limited number of vaccines available, what is the most effective way to use those vaccines? I mean, it was obviously a policy questions we faced early in the epidemic. We in Sydney just opened clinics, street clinics. Everybody who wanted went. But now those places are all shut. People can go to their local doctors, not many do. But health departments are responding to small epidemics by visiting sex on premises venues and vaccinating, which your data would really strongly support. But I suppose I'm encouraging you to, moving into the future, to work with policymakers and ask those really key policy relevant questions.
Yeah, for sure. I think definitely, I mean, the work I just presented looking at the forecasting total incidence, that doesn't have as much benefit in terms of like, okay, well, who should we really target? I mean, it's always going to be the case you should target people who are highly connected. But this kind of follow-up piece we're doing, which is looking at kind of the stratified approach, that actually could be very influential because it will allow you to forecast, for instance, incidents by sexual role without actually having to make assumptions about directionality. And so you could, in the UK, for instance, with mpox, we had a very much risk stratified approach. It was, have you had an STI in the last year, or have you had more than 10 sexual partners in the last 3 months? You could think of layering on different things to that. So, somebody who's had 10 unique partners in the last 3 months is actually a similar risk to somebody who's had maybe, one-time partner and has 4 recurrent partners or 4 concurrent partners. Or you can think of like, if there is directionality, versatile assortivity becomes very important. And so you could think of targeting either versatiles or targeting, the reason versatiles are important is because they're both at high risk from exposure, both at high risk from acquiring, and they also, if there's directionality, they're at high risk of kind of onwardly infecting. So you might have a vaccine strategy which targets that. You also might want to target receptives if there's directionality from inserted to receptive because they're just at higher kind of exposure risk. And so, yeah, I think this follow-up piece is hopefully going to be more kind of public policy oriented and more kind of deployable in epidemics. I think this piece we've done to this point is important for things like how do we forecast healthcare demand and healthcare capacity. But hopefully the follow-up will be like, if we have a limited number of vaccines, like how should we prioritize them?
Since nobody else has got a question, I also really like the way that you're beginning to extend this into other diseases which are not necessarily sexually transmitted. And, have you thought through, for example, with respiratory transmission, should we, for example, be targeting people who take public transport as opposed to people who ride their bicycle or car to work, people who are regularly exposed to those sort of super spreader situation?
Yeah, this is a really important question, and something I worked on during the COVID pandemic in the government was, most countries adopted this vaccine rollout based on risk, like age stratified risk. It was like older people to young people, but actually there was a potential that vaccinating 20 to 30-year-olds first, who were the dominant drivers of transmission, would have a more beneficial indirect impact on protecting older people because it would suppress transmission more quickly. You can think of different incentives for a vaccine program. Like you can think of directly protecting people from like severe infection, or you can think about suppressing transmission. And for instance, you can imagine a world where actually vaccinating 20 to 30-year-olds suppresses the R to below 1. And so then actually you kind of reached herd immunity. And again, that's driven by heterogeneity, right? Young people have very high contact rates, which typically drop off as you get older. But yeah, like as you said, also people who might take public transport would be a high risk. I mean, key workers were also targeted early in the COVID pandemic. But yeah, like
Curtis.
Yeah, a really great presentation. With, also not a modeler, I'm kind of curious with the kind of the simulations of, say, one node sexual activity over the span of 100 days and how connected they are with other people in that network. Is there, could your model, for example, account for how that one node or even the whole network might have increased or decreased sexual activity? So, for example, COVID, all the sexual activity dropped, and then that kind of changed the whole network. Or similarly, in Pride seasons when sexual activity, all the base number of, or everyone's sexual activity, or not everyone, but a lot of people's sexual activity will probably increase in that time, as well as maybe one person, specifically like you said in that example of, one partner every 2 weeks versus like 26 in a short amount of time. Like how does the model kind of account for that? And if there's any data, like should people be collecting some of that information?
Yeah. So with this approach, what we basically simulate epidemics which don't have any behavior change. We just assume everybody's going to carry on action. Obviously, in epidemics, that doesn't happen. In mpox, some people did change their activity, and there's papers which have questioned how much of the decrease in transmission was from vaccination, behavior change, etc. What's nice about the sigmoid attenuated approach is actually that attenuation, while we're hypothesizing it's mainly driven by depletion of highly connected nodes, that can also capture behavior change as well. Now, what this would struggle with is, okay, well, if you do see this early reduction in R, and it is actually principally driven by behavior change, well, you could see a resurgence later on. And our model as it is wouldn't be able to guess that. And so, any application of this needs to go hand in hand with actually kind of collecting data on the ground and understanding how behavior is changing. You would add additional parameters into this. But yeah, in doing this, it's versatile enough that you would be able to incorporate that. This is also maybe the vague benefit of attenuation models which attenuate based on attack rate or cumulative incidence versus time. Because obviously, say everybody took a break from sex for a few weeks, and then went back, the model would kind of push it down constantly. Whereas something by attack rate, that would just fix the attack rate where it is. And so it's a bit more behavior agnostic. But yeah, it's also something to think about.
James?
It's a bit unfair to ask all the question. I could have asked it before, but it occurred to me during the talk, so that's my excuse. I guess with the sigmoid function, you probably expected that to work well because your depletion of susceptibles will also form almost a sigmoid change in R. And I just wondered whether you actually generated from your networks sort of some version of kind of what that looked like, taking into account sort of network behavior as well. So kind of, if someone gets infected, you're taking them out of your contact network basically, and they have might have a lot of edges or not. Do you have some empirical version of that you generate for your networks that sort of you can compare a bit against what you're actually fitting here?
So we do compare against just like a heterogeneous network and the homogeneous one. And it is true that sigmoid does work best with the heterogeneous one anyway. I think the benefit of sigmoid is improved. I mean, the relative improvement is higher with MSM-like networks. And that is a feature of it being an overlapping one-time and concurrent network. But yeah, I guess looking back, it's kind of maybe clear that sigmoid would be the best. I mean, it's also has the benefit of being continuous in its first derivative and kind of quicker to fit and everything. But yeah, maybe it was a post-justification. And I think early on, I thought it might just be like a simple exponential decay. I mean, the reason sigmoid works well and is more robust is sometimes it just takes a bit longer for the epidemic to find those highly connected nodes. And then you don't have a likelihood function being biased by like a high early exponent.
But it captures that sharp change, I suppose, in transmission, which is sort of kind of a feature of these things more generally. So I think it's not that surprising that it kind of works better, but I'm curious if there's a bit of maths behind that as well.
Yeah, we did also spend quite a lot of time trying to solve this analytically. And it's really, really hard question, even just with a simple heterogeneous network, like it quickly becomes too hard. I mean, one other like takeaway from this work, we also early on tried to fit compartmental models with associative mixing to this stuff, and it just does not work at all. Even when you stratify your compartmental models by like activity group, it's very, very hard to get it to fit. And yeah, I think that's maybe an important takeaway.
Okay, thanks.
Any other questions? I think Andrew, Curtis, and James asked my questions. So thank you. I think we can probably wrap up, Will. So thank you very much, everyone, for attending the seminar today. And thanks to Will for a very interesting talk. I've got a lot more questions to ask you later.
Sure.
And thanks, everyone, for attending. And yeah, please thank you all once again. Have a good day.